Welcome. In today's explainer, we're going to build a clear framework for telling the primary generalized epilepsy syndromes apart. Getting this right is about so much more than just a label. It's really about precision in diagnosis, which, as we'll see, can have a profound impact on a patient's entire life. Okay, so here's how we're going to break it all down. We'll start with the foundational concepts, the stuff that applies to all of these conditions. Then we'll dive deep into the specifics of the key syndromes, absence, juvenile myoclonic epilepsy, and the more severe, Lennox-Gastaut. And finally, we'll pull it all together into a practical diagnostic framework that you can actually use. All right, first things first, let's establish the fundamentals. What exactly makes a seizure generalized in the first place? And how do we even begin to classify them from the very first observation? So the core concept here, the big idea, is that a generalized seizure isn't starting in one tiny spot. Nope, it originates across networks in both hemispheres of the brain almost instantly. And this widespread engagement is absolutely crucial because it almost always results in impaired consciousness, which is a key feature of this entire category. Now, from a clinical standpoint, when we see these generalized seizures, they tend to present in two main ways. The first is what we call the non-motor pathway, which you see in absence seizures. The second is the motor pathway, which includes a bunch of subtypes we're about to explore, like tonic-clonic, myoclonic, and atonic seizures. So let's start by going down that non-motor pathway. Here, we're going to focus on the absence syndromes and really look at the critical differences between how they show up in childhood versus adolescence, because wow, the prognosis varies significantly. This quote from our source material just perfectly captures the classic presentation of typical childhood absence epilepsy. The child just suddenly pauses. It's a brief lapse of awareness, but with no loss of posture. It gets mistaken all the time by teachers or parents for simple daydreaming, but the neurological cause underneath it is very, very specific. And here we see the electrophysiological signature. This is pathognomonic, which is a fancy way of saying, if you see this pattern, it confirms the diagnosis. It's a generalized, synchronous 3 Hz spike and wave discharge. Just notice that rhythm, a spike, followed by a slow wave, repeating 3 times per second across the entire brain, all happening on an otherwise totally normal background EEG. This comparison right here really highlights the critical distinctions. Just look at the prognosis. Typical childhood absence often just resolves by age 12, but in contrast, the atypical juvenile form, that requires lifelong therapy. And this huge difference in outcome is rooted in these details: a later age of onset, the chance of losing posture, and a very distinct, slower spike and wave pattern on the EEG. Okay, let's pivot now. We're going to switch over to the motor pathway to take a look at the most common adolescent onset epilepsy syndrome, juvenile myoclonic epilepsy, or JME for short. This quote, it just perfectly captures that characteristic myoclonus of JME. What we're talking about are these sudden, brief, almost shock-like muscle contractions. They're typically in the upper limbs, and they often happen right after waking up. Clinically, this is the classic spilling the coffee or dropping the toothbrush seizure, and it's so often triggered by sleep deprivation. So you see, the diagnosis of GME is fundamentally clinical. It really relies on this specific set of clues. That morning myoclonus, especially when it's triggered by a lack of sleep, that's the classic sign. It's also absolutely critical to know that about 90% of these patients will also have generalized tonic-clonic seizures. And just like atypical absence, this is the condition that requires lifelong therapy. The EEG signature for JME is just as distinct. It's characterized by a generalized polyspike and wave pattern. And that's exactly what it sounds like. Multiple spikes followed by a single slow wave, which clearly differentiates it from that 3 Hz pattern we saw in absence. And this discharge, it's often provoked by the same clinical triggers, like photic stimulation or sleep deprivation. Okay, next up, we need to address atonic seizures. Now, while they're a distinct seizure type, their primary clinical significance really lies in their role as a core component of a very severe epileptic encephalopathy. So, atonic seizures, or what are often called drop attacks, are defined by an abrupt and complete loss of postural tone. This can look like a simple head drop, or it can be a full body collapse that lasts just a second or two. The number one concern here, as you can imagine, is the significant risk of injury from these sudden falls. These atonic seizures are a hallmark of something called Lennox-Gastaut syndrome, or LGS. LGS is a truly devastating childhood onset refractory epilepsy, and it's defined by this diagnostic triad: First, you have multiple seizure types. Clonic seizures are the most common and atonic are characteristic, but, and this is important, never myoclonic. Second, you have significant cognitive impairment. And third, a very distinct EEG that shows a slow spike and wave pattern that's punctuated by these bursts of paroxysmal fast activity. Okay, finally, let's pull all this information together into a cohesive framework. This is where we see exactly why this kind of precise classification isn't just an academic exercise, but why it's so profoundly important for clinical practice. This table really synthesizes the most crucial point of all. Just look at the prognosis column. On one end of the spectrum, you have typical childhood absence with an excellent outlook. It often resolves completely. On the other end, you have LGS with a poor refractory course. The ability to distinguish between these syndromes, using the clinical history and specific EEG findings like a 3 Hz spike wave versus a polyspike wave, that is what determines whether a patient needs just a few years of therapy or if they face a lifelong condition with vastly different outcomes. And this brings us right to our ultimate takeaway, framed as a question. Think about it, the meticulous work of clinical and electrophysiological differentiation. It's not just some academic exercise. It is the practice that fundamentally shapes a patient's diagnosis, their treatment plan, their prognosis, and ultimately their entire future. Precision here changes everything.